today's webinar. We do have recordings of our 35 webinars available on YouTube. And finally, one of our most popular products, we do have free online self-paced trainings. And those trainings cover the most important aspects of IPSG, of quality management. We do have a course on prevention and control of infection. And all those courses, I mean, most of those courses come in 3 languages now. They come in English, they come in French, and they come in Arabic. And what's really important, that there are certificates available for successful completion of each of those courses. So if you take a course, you can stop it and continue it at the time you like. When you finish it, you take a quiz. If you pass the quiz, then you receive a certificate of completion for the specific course that you've completed. Okay, now after the webinar, what we like you to do is we like you to fill a survey of exit. Why is that? It's because today's webinar will also have certificates of attendance, not certificates of completion like in online trainings, but certificates of attendance. And to receive your certificate, after the webinar, you receive a link to a survey on exit and you fill it in. It's very short, it's about 5 minutes, but it has some really important questions. And those questions are the field where you type your name as you want this name to appear in your certificate. And you also type your email address. And please double check those 2 fields so that we can send your certificate to the correct address with the correct name. Now, we do have a requirement that you stay in our webinar for a certain amount of time to receive a certificate of attendance. Okay, so after the webinar, you receive your certificate, but please note the following information. Again, your name and your email appear as you put them in the survey of exit. We will not be able to send you the certificates immediately, but usually we send them in about 7 days, but we request up to 14 days because there is specific software that helps us with certificate generation, and we do need to account for that. If in 14 days, like not tomorrow, not the day after tomorrow, in 14 days, the certificate does not come, then please send us an email. You received an invitation from us, so please send a response to that invitation and we will receive an email from you. We will check your participation information and we will send you your certificate if everything is okay. All right? So these are the features of today's webinar. After the webinar, while you're waiting for your certificates, we encourage you to take our online training modules. The email with links to those trainings will be coming in 1 or 2 days. And I'm showing you one of our latest courses. This is the Prevention and Control Infection course. It's a new one. It's in English. It's available in English right now. And please test it. Let us know how we're doing. Or if you complete it, you can receive a certificate of completion. Okay. A bit more about the Zoom features that will help you with today's webinar. We do have interpretation feature. You can see that there's an interpretation button and you can click on that button and you can select the language that you need. This interpretation, simultaneous interpretation is available in French and in Arabic for today's webinar. Another useful feature is chat. This is where you introduce yourself. This is where you say hi to other participants, but this is not where you ask questions and answers, because it is likely that information in our chat is not recorded. This is why we want you to use a separate button called Q&A to ask your questions. And when you press that button, there is a menu and you can type your question and that question is recorded. So we know when the question has been asked and we do our best to respond to it either online or we responded afterwards. Okay, so these are the features that you may need and I welcome you to today's webinar. Enjoy.
Thank you very much, Natasha, for your wonderful introduction, as always. So hello, everyone. Welcome to IFC series of webinars. We are happy to see you all after the short summer break. I hope you had good time. For those for whom it's summer, for some of you, it might be winter. So today we are going to talk about healthcare quality and patient safety in outpatient settings. When one is talking about patient safety standards, about accreditation, often it's hospital requirements. Often this applies to facilities that do complex procedures with longer stay for patients, and it's justified that risks are higher and patient safety is very important in such a setting. And what about outpatient care? With obviously much shorter stays, much shorter visits to the facility, and less complex procedures, sometimes no procedures at all, just conversation with the doctor. Does it mean no risk? Does it mean patient safety is not important at all and no standards apply? Let's discuss today. And our first speaker is Dr. Ajibike Oyumi, a part of IFC healthcare quality team. I think many of you already met Dr. Oyumi virtually or even in person. Ajibike, the floor is yours.
Thank you, Julia. And hello to everyone. Good morning, good afternoon, good evening, everywhere you are. Welcome to this interesting webinar. I find it particularly interesting because as I was preparing for it, it actually, I realized that I probably hadn't given it a lot of attention or as much attention as I have given thought to quality in hospitals. And I guess that's because I've worked largely in hospitals, even though I do run outpatient services. But I'm sure that is probably the case with most people, except those who actually work in outpatient centers. Even though for many of us also, our outpatient centers reside in hospitals and we focus on the hospital. And again, because most of us receive our training in hospitals and we don't do too much outpatients. So I think it's really, really important that we look at quality in the outpatient setting. So when we talk about outpatient care or the outpatient setting, what do we mean? I guess
Ajibike, I'm sorry, we don't see your slides.
Uh-oh, I beg your pardon. Please give me a moment. Thank you.
Yes, let me know if you want me to show them.
Yeah. Oh, I deeply apologize for that. It's coming up. Can you see it?
Yes, we can see the second slide.
Not in slide, yes, but not in slide mode.
Not in the slide mode, no.
No, slideshow mode, okay. So this was where I started from.
Yep. Yes, now we can see it.
Nice. Okay. So I was going to define what outpatient care is. And when I was doing that, I thought people would say, what do you mean by, why are you defining outpatient care? We all know what it is. But then I realized that outpatient settings differ based on the country you're coming from. So we have different types of outpatient settings in which we'll be talking about. But the main thing about outpatient settings, irrespective of what that setting is like, what kind of center you call it, it is one that refers to medical services, whether it's, along the spectrum, diagnostic, treatment, or follow-up. Treatment including things like rehabilitation, provided to patients who do not require hospitalization. The main definition there to be underlined is that it doesn't require hospitalization. But it emphasizes convenience, access. So outpatient services are usually more accessible than the hospitals and comes at a lower cost. Of course, because there's no stay in hospital, there's no overnight stay in hospital. So it comes at a lower cost. And it's a really, really important part of healthcare. it is said that 90% or more of care can be delivered in the outpatient setting. And so if we find out that 90% of our people are accessing care from a particular center, then I guess it behoves us to make sure that the care that is delivered in those centers is of top quality and it is safe. So the settings for outpatient care include, primary health care, you have specialist clinics, urgent care centers, they call them in some places, where people go to get care when they're ill, but it's not an emergency, right? Then you have ambulatory surgical centers, telehealth services, which we all have been doing a whole lot more since COVID. It's a form of outpatient setting, right? And then in some areas, in some jurisdictions, you have behavioral health clinics, which are separate. You have rehabilitation centers where people go to get physical rehabilitation. So physiotherapy, rehabilitation services, occupational health therapy, and all that. And then you have community health centers. Some jurisdictions have what you call the community health centers, where those who are, it combines a whole lot of services beyond just healthcare. So you would have dietary services, you have the opportunity to actually interact with others for mental health. Okay, so all these services are part of outpatient services. Now, what are the domains and the characteristics of quality in outpatient services? It's the same that we know, the STEEP now, right? Safe, timely, effective, equitable, efficient, patient-centered, and integrated. But over and beyond that, there are certain characteristics that we need to think about for outpatient services that are slightly different from what we do in inpatients. And that's, the fact that it has to be very comprehensive. Yes, we do have comprehensive care in inpatient, but for outpatient, we must have that deliberately at the back of our minds, because if not, we tend to forget things and, different things fall through the cracks. We have to be very coordinated. You have to be coordinated in inpatient, but you have to think about it more so in outpatients, because you actually have to go for it. You have to refer your patients deliberately. You have to have deliberate conversations as a team. Unlike in hospitals where you might actually meet in corridors, in different coffee rooms and things like that. In outpatient settings, you have to do a bit more coordination of care, deliberate coordination of care. It has to be very, very people-centered, because like I said, this is where 90% of care is delivered. It has to be continuous. Now, we're talking about continuous because I'm sure if most of you who've gone to primary healthcare centers for acute short-term illnesses might find out that you're seeing different doctors at different times for different visits. So in fact, in some places it's so I don't want to call it bad, but it's such that you go for a visit, you're asked to come back for results, and it might be a different doctor that's seeing you to give you your results. So we're saying for quality outpatient services, we need to think about that continuity of care and how patients get care. And of course, accessibility is the main stand of outpatient services. Now, why are we talking about this? If you remember our title, we did ask, do we think that outpatient services are any less risky? Well, not so. So what I've done here is to help us look very quickly at some of the risks, how we compare the risks. I'm not going to read through because you're going to get the slides. I'm just going to point out some of the very key things, right? So the type of care you get in outpatient versus inpatient. Inpatient is more routine. It's more routine care, it's more minor ailments, and it's more manageable procedures. Of course, the more complex procedures are done in inpatient because patients have to be fully monitored. In outpatients, when we're talking about patient monitoring, that is one of the risk areas, right? Because patients come into the hospital, they get care, and then they go home, and we're not able to monitor them as closely as we do in inpatient. And that's a risk point, because you give them medication, you do procedures, and they go home. I know that now with the advent of a lot of AI tools and, increased technology, we're better able to monitor patients, but it's nothing near what we do in inpatient services, right? So that is a risk point. Length of stay, beg your pardon, I've moved. The length of stay, of course, is much shorter. Patients even, go home. That's the definition of outpatient. They go home. However, acuity in outpatient services, you see more of chronic patients. We do see the acute short-term illnesses, the febrile illnesses and things like that, but the bulk of outpatient services are chronic illnesses, and that is, again, where some of the risk is, because the chronic patients with multiple comorbidities can make it risky. In inpatient, of course, there's higher acuity, which in itself is risky, but it can be a different kind of risk, but we have to bear that in mind. Care coordination, like I said, multiple people seeing same patient for the same illness with very little coordination. In outpatient, the risk of acquiring hospital-acquired infection, of hospital-associated infections is much less. And that's a good thing, but that doesn't mean it's zero. So you still have minor procedures, injections where there's risk. Emergency situations can also be a risk for those who run outpatients if you're not prepared for the emergency situations, unlike in hospitals where you might have the anesthetist, those who are trained, the code blue team. In outpatient, we tend to overlook that. And so that will be one takeaway point. Think about your code blue teams and how you manage patients that may be deteriorating, and possibly begin to do code blue drills. We'll talk about that. Patient engagement. The risk for outpatient, usually stems from lower patient engagement, and I'm sure you can understand why. In the outpatient setting, we haven't really had time to bond with the patient, if I can use that word. We haven't had time to get the trust of the patient. And patients are very well aware, so you need time to talk to them. It's very difficult for people to come in each time and bare their souls to somebody new each time. Unlike in the inpatient, where usually you would have a doctor who comes to see you regularly. You have your nurses that are changing shift. Oh my goodness, my power is about to go out. You have your nurses, even though they're changing shifts, oftentimes they're coming back one after, during the day, and there's an opportunity to build trust. In outpatient services, that may not happen, except you have family doctors that people come to see all the time. Oh my gosh. Medication management can also be a problem because, we did talk about the fact that patients are usually chronic patients, so they're on multiple medications, and polypharmacy is a major risk for these patients. So we need to be very careful. In outpatient services, the main medication kind of adverse event or error that happens is related to medications. So it's been said, the WHO published this, that about 4 in 10 patients are harmed in primary and outpatient healthcare. I mean, that's a huge number. If you think of the number of people who go through outpatient, who receive outpatient services every year, every day, if you think that up to 40% of these people can be harmed, then you know why this is a real big issue. So now, what are the types of errors that we encounter in the outpatient setting? Of course, there's the diagnostic errors. Okay, and it said that about 5 to 15% of patients in outpatients have diagnostic errors. This is particularly a problem because it leads to the wrong treatment. Now, not only are they receiving the wrong treatment, but there's a delay in receiving care for the right treatment. And in these past 2 days, we've just been talking around the world about diagnostic errors. Okay, so I won't go there. Medication errors, like I said, are the main problem. Then, of course, you have surgical errors. especially when you don't have good identification processes and you're seeing the patient for the first time. Many times you're seeing the patient for the first time in ambulatory care when they are having procedures. Okay, communication errors are big between the patient, especially, patient provider communication. You're having to give patients instructions and they're going home. They're going away. You're educating them in a very short period of time. You're giving them instructions in a very short period of time and they're going away. They don't have the opportunity to ask somebody else again in 1 hour if they've forgotten, and then another healthcare provider in 1 hour because they've forgotten. So we have to think about that as a major source of problem. Of course, follow-up errors. There was a research that showed that up to 50% of patients do not receive timely follow-up or timely communication of their test results. I was blown away when I saw that, right? And all the preventable adverse events. So what's the impact of these quality issues in the outpatient setting? I'm sure you can imagine them already. They're very similar to the ones that we have in the inpatients. But one of the main problems is the delayed or missed treatment because of the results that we talked about, right? Then additional visits. Additional visits cost time, patient time. It costs income. It takes up the time of the providers. And so that's a problem given the number of visits that happen, as we've discussed. Additional testing, preventable readmissions to hospitals, or even preventable admissions into hospital. So what you call the outpatient sensitive conditions, where they could have been managed in outpatient to prevent admission. But when we have quality issues, patients end up on admission or they get readmitted. And of course, there's the increased morbidity and mortality, the emotional pain and suffering, and the cost associated. So very quickly, what are the causes of this poor quality? Fragmentation of care. Like we said, there's system level issues. If you think about them in buckets, fragmentation, inadequate infrastructure, especially in the emerging markets, right? We don't have all the infrastructure we need, the equipment, the buildings and all that. Major problems with insurance, right? Because the insurance and reimbursement issues, they're not paying, so people are not getting the care they need to get. Then, of course, there's the provider-related factors, and I think we all can relate. Burnout, fatigue, and then inconsistent or non-availability of protocols. The range of conditions that outpatient doctors have to deal with is so much wider. For specialists, everybody already knows. As a gynecologist, you're not going to bring me a patient with, you're not even going to bring me a male at all. I don't see males. So it already narrows down. Cardiologists will see only people with heart conditions. Maria, your hand is up. Is there a problem?
No, everything is good.
Okay, all right. Sorry. So the range of patients, of conditions that primary health or family physicians have to deal with is really wide. And that's why they need protocols, because they cannot know it all. So when they don't have adequate protocols that would enable them deal with this wide range of conditions, then there's increased risk of misdiagnosis. Patient-related factors include health literacy. Many patients do not understand their care, and even to be able, they find it difficult to even express themselves and give you all the information in that short period of time that is required. Okay, and then of course all the cultural issues. We've talked about communication before, right? Communication between provider to provider, patient to provider, and then the overload. Imagine the amount of information we have to give to a patient in the 15 minutes or 10 minutes that we see them, and yet we expect them to understand. Then there's inadequate performance metrics. A lot of work has been done around the world on inpatient, on various disease, measuring performance, but there's not as much attention has been paid to outpatients. Insufficient feedback mechanisms as well, right? We pay a lot of attention to inpatient, but not to outpatients. And then the limitation in electronic health. So very quickly, as my lovely colleague Julia says all the time, practical tips. What should we do to make sure that we deliver better health? So I'm going to give you a few practical tips. I'm going to run through them because of time. You will get the slides and you'll be able to read through them. So I deliberately left the information in place. You know, it looks a bit busy, but it's so that you can use them later. Okay. So clearly, one of the things that we need to do is to promote a culture of safety. It has to be top of mind. And we have to learn. We have to encourage reporting of incidents, and we have to learn from the incident. So we have to develop a system that allows us to do this. Make your staff feel safe to report incidents, misdiagnosis, wrong medications given. Sometimes you give a patient the wrong medication and they leave the hospital with it. We have to be able to pick those things and correct them. Consider having regular safety meetings for those of you in outpatients. It's not just for those in inpatients. When you come in the morning, before you open your doors to the patients to come in, think about which patients are we seeing today. A lot of your patients may have appointments. So you may be seeing particular patients with particular difficulties, maybe serious comorbidities. So Mrs. XYZ is coming in today and she has chronic renal disease, diabetes, and this and that and that. What are we doing for her? What are the things we need to do today? What are the safety concerns we have? This is a good practice to have if you can do that. Engage patients in their care. This we cannot talk enough about. The patient is with you for 15 minutes in primary care or even in a specialist clinic, or even 4 to 6 hours for a patient that has procedures. That patient is going home to manage themselves. So we have to engage them well in their care because they have to look after themselves. You have to provide education and you have to think about your safety checks, right? All the patient identification, the care plans and things like that. We have to ensure we're communicating clearly. Use the SBAR tools like we use for the hospitals, but they work in outpatient as well. Clear communication, we cannot overemphasize. And consider providing written patient instructions, even verbal instructions. Now we have a lot of, WhatsApp. In some parts of the world, WhatsApp is a beautiful tool. We were just discussing it today. It's a very easy way to communicate. Please use those. Give patients written instructions. You have said something to them. Many times patients are overwhelmed. They're in pain or they are shocked. So you suddenly told somebody they have some chronic condition and they are, overwhelmed. And yet you've given instructions. By the time they get home, they've forgotten everything you said. Send them something written so that they can look through. Get their medications written. Follow up appointments. Early warning signs or warning signs to look out for if they've had a procedure. What should you be looking for? Signs of infection at home, right? If there's excessive pain, if the wound looks like this or like that, or you see this or that, give it to them in a written way, and then they can refer to it. Okay? Implement chronic disease management programs. These are programs that have now been standardized, what you should do. You need this because, again, like I said, patients have to manage themselves. Chronic disease patients actually have to really learn how to manage themselves so that they don't overwhelm the system. And then secondly, so that they don't run into trouble. We must equip them with the knowledge and the skills and the confidence to actually manage their condition. And that way they stay out of hospital and they stay healthy. Okay, we have to prioritize infection control, hand hygiene. Hand hygiene always sounds like something so simple, but it can have profound impact. So in outpatient services, we still must consider hand hygiene and provide all the resources. Sterilization and cleanliness, we can't talk enough about. Even for the small things, right? Otoscopes for looking into patients' ears. I find out that I go into hospitals and they don't have a procedure for cleaning those things. right? You don't clean the stethoscopes. And these are the things that you use to touch so many patients. So we must develop procedures and for sterilization and cleanliness. We must utilize checklists and protocols. A lot of these are already online. Download them, use them, standardize the policies and protocols. Do not expect anybody to know everything in their heads. Disease conditions, right? Checklists, decision support tools. So if you see the patient has chest pain, check this and that. If yes, do this. If no, do that. You know, all those are very, very useful, and they're very easily available now. And they are very important for the support of quality in outpatients. Medication management, we can't emphasize enough. We've already said that the commonest medication errors that happen in outpatients is medications. Teach patients to manage their medications. I remember, you know, my mother-in-law, the first time I saw her medications, I'd been away and I came back and I said, so what medications are you using now? And she pulled out a sheet of, she had her Ziploc with her medications, and she had her piece of paper, and she had written every medication that she was given. And the ones at her last clinic, the ones that had been stopped, she had put a line through, and she had the new ones written in. So I could tell all the medications she had been on in the last 3 to 4 months or more. And then I could tell which ones had been stopped and all that. We should encourage our patients to do this. If we can, develop cards for them. As much as possible, have your patients' medications written out and reconciled. Because of the chronic diseases, patients are on multiple medications, and sometimes we start new medications while forgetting to tell them to stop the one that they were using before. And these patients have these huge bags of medication that they're carrying around, and they're just swallowing them. Adverse events. So medication reconciliation is very important. And medication safety, we have to empower the patients to know which medications they're using, the names, and what is safe and not safe to do. Okay? Of course, we must leverage technology for safety. We've gone past where everything is on paper. We should be using our electronic health records to support the delivery of our care, to track patient information, right? Configure the health records when a patient has had a test. There should be something that flags for you that you need to check this patient's test. Otherwise, you get a terrible result and you don't see the patient for 3 months, by which time it's late. Alerts and reminders. It's time for your cervical screening, cervical cancer screening. It's time for colon cancer screening. It's time for HbA1cs, right? Let's use these alerts and reminders. And the healthcare record, the healthcare platforms can actually, health record platforms can actually be configured for this. Let's monitor and track safety metrics, right? Look at your incidents. Look at your outcomes. If you're in outpatients, how many of your blood pressure, your hypertensive patients are controlled? How many of your diabetic patients are controlled? How many of them have had their foot screening? Let's collect this data and use it for improvement. Of course, we have to train and educate patients, staff regularly. Hospitals do that, and we should do it in outpatients as well. We shouldn't assume that because outpatients seem simpler, it's okay to not, remain on top of the game. And we must also do simulation drills because we don't see too many acute and severe conditions. The day they happen, it becomes a problem. So do your code blue drills once in 6 months at least, right? And look at what other kind of conditions, diabetic ketoacidosis, right? Obstetrics, patients are coming to deliver. Think about those simulation drills that will help you. And then workload management is very important. Doctors seeing 70, 80 patients a day is cutting disaster. So let's think about how we would manage the workload so that they don't burn out and make resources available. In summary, Outpatient services are usually the first point of contact for most, and that is when we can either pull them in, get them to trust the system, pull them in and let them stay, or we can actually drive them away. 90% of care occurs in the outpatient setting, so it's very, very important. Even though outpatient care is usually less complex, it doesn't mean it carries less risk or there's less risk of adverse events. We have talked about measures that help us to deliver quality care, and I've given you, how does Julia say, practical tips to take home such that you're able to deliver good quality care. Bonne chance, everyone. Thank you.
Thank you so much, Jibike. I hope that some of the slides you can actually print out. And by the way, we definitely share the slides with all the participants after each event. So don't worry, you will get all the slides. And some of the slides of Dr. Jibike with practical tips, I think you can even print out so that they become checklists and your reminders for what needs to be done in your outpatient setting to make it safer. To me, it really sounded like a revelation in many points, although I'm a healthcare quality manager for a long time. But even if you think about it as apart from the hospital, you really are amazed how many aspects you need to consider and how many standards apply, despite the fact that at first glance, really the procedures and the interventions seem very simple, but they are not. And actually, it made me think that this shorter interaction with the patient doesn't make the whole process less risky. It makes the whole process more risky and puts more responsibility on the doctor. And also what we need to consider these days is that in the old times, stay in the inpatient was very long. Doctors wanted to make sure that when the patient is discharged, he is absolutely recovered. He's healthy and able to live his life, to continue living his life. These days, inpatient stay is becoming shorter and shorter, putting more responsibility on the outpatient care unit and putting more responsibility on the patient to continue some parts of the treatment at home. And that part of treatment sometimes is involving high-load medications, for example, for chronic diseases like anticoagulants, which have lots of side effects. And this also needs to be explained to the patient because patient becomes also a very important link in the chain between doctor and nurse and the patient. So the patient is not now just following the orders of the doctor. Patient needs to understand that certain symptoms might become early warning signs and he needs to contact the doctor after he goes home. So in order to help this, we really need to communicate very well with the patient. Thus, communication in outpatient care becomes critically important. So, and also what is important to remember that certain things might happen even in the outpatient setting, despite a lack of like surgeries or other complex procedures. Just a case from my own experience, from my own hospital. One person, not even a patient, a staff member, came absolutely fine to work. And then around 10 a.m., so it was beginning of the working shift, and he was not a doctor, not a nurse, but a back office staff. He felt strange and he decided to go to cardiologist. He said he had kind of chest pain, just couldn't explain how he felt. Doctor was very busy. So he said, can you please come to me after an hour and a half because I'm having patients one after another. So the staff member said, it's fine. He went 2 floors up to his room, fell and died at the entrance of his room because obviously his condition was very acute condition. So of course it was an incident. Of course we had a lot of root cause analysis, etc. And the Code Blue team was not properly prepared for this moment. So it happened in outpatient setting. It happened to a person who didn't seem critically ill. The person was walking by he was walking by himself. He could talk. He could explain, etc. He seemed fine. Still, something went wrong, and we lost this person. We lost this patient, this staff member. So It basically shows, again, as Dr. Ajibiki said, how important become early warning signs and critical results in the outpatient care, because the fact that the patient came by himself and seemed fine does not guarantee that he's actually fine. So I'll pause here, just we can continue this conversation forever, but I want to introduce our next speaker, that is Dr. Ali Shalaby from AXA OneHealth Egypt. Dr. Ali, the floor is yours.
Thank you so much, and thank you for everybody for attending. I see a very, very full room, and it's amazing to have everybody tune in. So I will talk today about our clinics that are in Cairo in Egypt. I believe you'll be sharing my slides for me.
Yes, Dr. Ali, let me just put them on and let me know if you can see them, okay?
Amazing. I'll be talking about really 4 things. I'll let you all know a little bit about who we are within AXA and what our standards for the quality are, and how we built our clinics from the ground up with quality standards. So that's the second slide. Thank you, Natalia. And finally, I'm going to talk to you about a study that we are in the process of publishing about outpatient safety. So if we jump in to the next slide, we'll start with who we are. And the next one, please, Natalia. OneHealth is a subsidiary of the AXA Group. AXA, you might have heard of as a leader in insurance worldwide. It's in over 50 countries around the globe. We offer an integrated health approach, which is kind of a fancy way of saying it's a one-stop shop. Most of our clinics will have a lot of the services that our patients need. We have over 700 doctors with 30 specialties and subspecialties. And besides the consultations, we offer advanced diagnostics and lab services. We also have a digital solution, which I'll talk about in a couple of slides. And we really focus on having a very high quality patient experience. So if we go to the next slide, please, Natalia. We offer what we call a phygital approach, so physical and digital, where a lot of our services are obviously face-to-face, but we offer a teleconsultation service as well in the primary care and also in secondary care. So if you see the spectrum at the bottom of the slide here of what one can offer, the OneHealth clinics is mainly a mix of primary and secondary care. And very recently, we've added an inpatient facility to one of our locations in Cairo. So if we go to the next slide. For the outpatient, it's not just consultation. So like we've seen in a previous slide, there are lab services, there's a nurse assessment, there are things like minor procedures, like an ingrown toenail, suturing, minor cosmetic procedures, and non-invasive cardiac lab. And as you see on the right-hand side, a whole host of specialties and subspecialties. If we go to the next slide, it's our digital health service. So we have either through the application or through the call center, our clients can reach a family medicine doctor 24/7, or they can book with a specialist doctor like a surgeon or a cardiologist or a pulmonologist, but that would be in working hours only. Then the final, Natalia, next slide, part of our offering, like I just said earlier, is the inpatient, which is a small unit that offers mainly day surgery or short stay. And it kind of completes our portfolio of being a one-stop shop for our patients, focusing again on the patient experience and also creating savings for the insurance company. The specialties are a range of the specialties that we see in the clinic anyway. So but the top really performing, or the top numbers, are in the general surgery, orthopedic, and the ENT. So what are the AXA standards? So Natalia, next section, please. AXA, like I said, is an insurance company, but part of the insurance is health, and there is a strong focus on health risk. So in the next slide, we'll see that AXA looks at health at 3 different levels. As a partner, so partnering with the patient, with the client, to help them to get the right care at the right time, to gain trust and build trust, and we heard about trust in the previous presentation, and to get a holistic approach for health. So it's not just an insurance, but also a kind of a preventive approach for the patients. AXA as an insurer, so they also look at networks of providers that would give value for money, with efficiency and savings. There should be benchmarks for the providers, so not to allow them to run away with their thoughts and desires for profit-driven activities, and to enhance the medical contracting and insurance pricing, again, to make it more value for money, both for the insurer and for the patient themselves. Then the most recent addition is a healthcare player. So here, this is where OneHealth and a lot of other AXA entities worldwide come into play, where they are actually offering the service themselves. They're not contracting it through other hospitals and clinics, but they actually are the ones who own the service. And worldwide, we serve more than 1 million patients every year now. So we need to make sure that the medical facilities are best in class, that there is a good risk management framework, and that there's no conflict of interest, of course, between the insuring side and the medical provision side. And naturally, to make people want to come to our facilities. Then the next slide shows us what OneHealth specifically has done in that field. I'm not going to read through this whole list, but we have been one of the leaders issuing the guidelines for the AXA group for patient safety. And we've used international standards like the WHO and JCI, but we've also used local standards. The Egyptian standards are called the Gahar standards, to deliver these documents, because again, in the past, a lot of the quality and risk assessment frameworks for AXA were related to either insurance or financial ones, and not, there were obviously health-related ones as well, but not as a health provider. So being a provider of the healthcare is the newest addition for AXA as a group, and we're very proud at OneHealth Egypt to have been contributing to these guidelines. The next section, Natalia, please, is how we built the quality in our clinics. So we've used, next slide, the JCI standards. Again, a lot of you will be familiar with this list, and I'm not going to read through it. And the next slide, and the one following, is just a breakdown of the bullet points in the initial slide with examples of the domains that one can work on. So in patient rights, for example, we need to make sure that there is informed consent, confidentiality, things like medication management, how we are ordering and prescribing, quality improvement, how we're reporting on incidents, etc., etc. And it's important to mention that, yes, these standards were mainly for an inpatient or a hospital setting, but as is the purpose of this presentation, we need to extract what is relevant for an outpatient setting, which is what we did when we were building OneHealth from the scratch. So Natalia, next slide, we can probably skip because it's just more of the same, more of the elements. And we can stop here and have a look at a picture of one of our clinics. So what we've done in designing the clinics is not just put protocols for things like infection control and electronic medical record usage and medication management, but even how the clinic looks and feels. So we made sure that there were things like adequate lighting and good visibility so people wouldn't trip and fall. Again, the floors have to be obstruction-free. They have to be non-slip, so the quality and the choice of the material that one is putting on the floor, it needs to be a safe one. We made sure that there were minimal recesses, so there weren't any nooks and crannies that would gather a lot of dust and would be easy to clean. So this is important for infection control. Things like non-slip chairs, just like non-slip floors, and chairs that were sturdy enough to be able to withstand some people with heavier weights. We wanted to have something called the biophilic design, so it would be a bit more home-like and cozy and warm. We can't put natural plants because of the infection risk there. So if we did put plastic plants, they had to be easy to clean with very large leaves, nothing that's too small, again, that would gather dust and be an infection control risk. Then in the next slide, Natalia, we have also looked at quality metrics for the doctors. So we set certain domains and KPIs so that we would be able to make sure that the performance is up to our standards. So we broke it down into these 3 domains that you see: the clinical, the business, and the personal. So things like quality of documentation on our electronic medical record, the number of complications or medical errors, and I'll get to that in our study in the next section. And business, things like utilization of the doctor and doctor productivity, because whether you are owning or renting the space for the center, you need to utilize the space as smartly as possible. You don't want to have rooms that are empty for long periods of time. And the ability to be revenue generating, so whether we can convert from in-clinic, from consultations to in-clinic procedures, etc. And then, of course, on a personal level, that the doctor is punctual, that they don't cancel their clinics, that they are nice and friendly with the patients and explaining everything correctly, that there aren't too many complaints from the doctor-patient relationship point of view. And this is particularly important for doctors who are on a consultant or a short-term contractual relationship with the clinics, that they are not full-time employees. The next slide, Natalia, shows us also that we have an incident reporting system, which is the OVR, short for Occurrence Variance Report. But there are many ways of collecting and recording incidents. So, for example, in the UK, there's a software called Datix. So when you say you're going to Datix it, that means you're going to report basically an incident. In OneHealth, we just call it OVR. And as you see in front of you here, this is the pathway for what happens to an OVR, and the centralized reporting system for the whole AXA group is called the Scala. It's just the name of the registry that collects these OVR reports. If you don't have fancy software, Natalia, on the next slide, you can just, and you must really record them in a simple Word document or an Excel sheet. Natalia, if we can switch to the next slide, please. You can just have simply what your critical incidents are and the actions taken. So this kind of recording system, the documentation system, is key to have a risk registry to follow up on them, so you can make sure that you're not missing anything. And it really helps on the long term in terms of strategy and decision making. It will highlight, recurring issues and gaps for where you might need to put some policies or to inject a little bit more of capital in order to address these weaknesses. Next slide, Natalia, please. This risk registry, you can then, in OneHealth, what we do is we monitor it in a visual system. So in this matrix, we divide them onto 2 axes. One axis is the consequences of this particular incident, whether it's has caused, what its severity is, if it has caused patient harm or not, if it's caused financial loss, and whether it's disturbed operations. And on the other axis, how probable it is. Is it a rare event? Is it a frequent event? Is it an often event? And then these numbers we put as an example. So you can then visually appreciate the number and frequency and the severity of your incidents, and then make these important strategic decisions of how to tackle them. The next slide, please, Natalia. Then we have set a lot of key performance indicators for our outpatient clinic. As you recall, when we were talking about setting up the quality, we said some of it is related to things from the build of the clinic. Some are related to the doctor's performance, but then others are what we see here on the slide. So things related to enhancing patient safety, things related to process and efficiency. So things like appointment scheduling, for example, and then KPIs to facilitate continuous improvement. So taken from the previous slide of visually representing our risk registry, data-driven decision-making. Examples. So Natalia, next slide, please. This is the last slide in this section. What our quality KPIs are divided into are things related to processes and things related to outcomes. So we have KPIs for our scheduling efficiency, the number of booked encounters, for example. If a patient has left without a visit for any reason, I showed you that we have an application where we can book appointments. So the number of bookings that come in through the app, the number of walk-in clients. Waiting time is a very big differentiator for OneHealth in the market. Previously in Egypt, people could wait for hours to see a doctor, and we have come in to disrupt that, and we have become a leader in managing patient waiting time. So it's a very, very critical part of what we offer, and therefore it is one of the top KPIs that we look at. Then more things and processes like documentation accuracy, how we use and utilize our electronic medical record to its optimum potential. And the no-show rate, so how many people would book an appointment and then not show up. This is important in high-flow situations like physiotherapy, for example, where we have somebody who might need multiple sessions. We've got a limited number of physiotherapy cubicles. It is a very popular service. So if somebody cancels, then or if somebody overbooks, even there are possibilities that other clients may not find slots. So it's a very delicate balance that we need to maintain so that we can give everybody the service that they need. Then the second domain for the outcomes is things like patient satisfaction. So we've got two ways of gathering this data. We have on-site feedback through a tablet, but we also have our client team and our call center that proactively call patients to assess their satisfaction. And we have also through the call center a negative feedback and complaints management system to gather all this data. Then we also look at things like surgical referrals and lost opportunities. So if somebody, for example, would come and do an initial consultation in our clinics, but then decide to do their intervention elsewhere, we try to find out why and improve our offerings. We like to also look at the follow-up frequency. So if somebody sees a doctor, if they need to see them again in a week or a couple of weeks, we make sure that that happens. We look at clinical outcomes, things like complication rates, and of course, whether we are cost effective in running our outpatient services or not. So that's the second section of my talk today. The last one, so Natalia, next slide, is the result of the practical study that we ran over the past couple of weeks, looking back at 4 years worth of activity in our centers. Next slide, please, Natalia. So the purpose for it was to identify, Natalia, can we go to the next slide, please? Yes, thank you. The purpose was to identify what incidents we actually had in an outpatient setting. to look at whether they were preventable or not. And then, of course, we needed to develop strategies if we found any gaps. Next slide, please. Because this is still an unpublished study, so I've removed the numbers for now, but watch the space and we'll let everybody know once we've successfully published it. But what this slide shows is that, as we heard also in the previous presentation, that one of the top risks that we found practically in our clinics is a medication error, followed by infection control risk or an infection risk in general, physical injury, safety risk, and toxicity. The medication errors were either related to an allergy, so if the allergy was not correctly documented, or if somebody had not documented an allergy at all and the patient turned out to be allergic to this medication, or an error in a medication name. So, and especially because we use an electronic medical record, so if there's a drop-down menu and the medications might look the same, then this might lead to this type of error. And the third, so one of the top three really errors related to medications, the third top error is an error in dosage. So again, this could be related to the data entry on the electronic medical record, or a simple human error if the doctor was made a mistake in writing the dose. Infection risks could be related to things like the sterilization or the use of certain disinfectants. But really, it was also, we can't forget the COVID-19 wave that hit the whole world. And so what we identified was an error in triage of patients. So if they were not sent to the right section of the clinics during the pandemic, or if a patient had some kind of infectious disease, for example, like also an upper respiratory tract infection or influenza, and they did not report it properly on arrival. Physical injury was related to things like wet floors that could be slippery and somebody fell, or the opening of cupboards and somebody that might be inadvertently hit by an open cupboard. Safety was mostly related to things like physical safety with stolen items, if there wasn't adequate monitoring for that. And the toxicity is the tiniest, smallest there, and it was really one event that there was a hazardous material that was left unattended and not adequately labeled. Interestingly, next slide, please, Natalia. What we found was that the majority of the incidents were preventable. So some of the literature says that about 20 to 30% of outpatient-related incidents are preventable. In our study, they were a lot more. And this means that there is a huge room for us to improve to reduce these incidents. Because if it's not preventable, all you can do is risk management and try to anticipate things. But if it's preventable, then definitely there is room for improvement there. Again, in terms of near misses, so things that were almost going to happen, these were less than 30%. So again, these two bar charts here tell us that there is a lot of room for improvement for what we are doing in an outpatient setting. The next slide, Natalia, please, just gives the examples of some of the incidents that happened. I think I mentioned them, so we won't go through them. And then the final slide, Natalia, please, is what we have recommended in terms of our study. So we found that we need to enhance staff training to focus on the medical errors and things related to infection control. We need to revise our protocols relating to things like infection control and safety. The technology needs attention, so maybe we can track and manage incidents in a more efficient way. And our reporting system needs to be more robust. More people need to be encouraged to fill out these OBR incidents and maybe find an automated way to analyze these reports, because the more we work, the more aware people are of OBRs, the more we will receive. So we need to be efficient in managing them. And we need to always repeat this type of study. So we need to then reinvestigate the new measures that we have put in place to see that we are making or to prove that we are making a difference, and to look into other factors that are affecting patient safety. If you do a quick online research on outpatient safety, you'll see that there are around 3,000 publications per year along this topic. So in conclusion to our study, the areas for improvement were dealing with medication errors, infection control as an urgent top 2 findings. And our goal is to then reduce these risks and enhance the outpatient care through improved safety protocols. And here, really, I have to thank our quality team led by Dr. Hiba Afifi, who's really done a fantastic effort in making sure that we've maintained the global access standards, and that OneHealth is a leader in this in the market. Thank you so much for your time.
Thank you. Thank you very much, Dr. Ali. Great presentation. Thanks a lot. And thanks a lot, especially for sharing the information about the study, which is really eye-opening, because it basically answers the question, the tricky question that we were asking in our invitation, and the tricky question that all skeptics are asking when they are talking about outpatient setting. What can potentially go wrong? Lots of things can potentially go wrong, yes. And you actually listed them in a very clear and straightforward way. Thanks a lot. And by the way, this study also proves the importance of incident reporting in outpatient care. Not all hospitals pay enough attention to incident reporting, but outpatient care, again, they think, it's less risky, so we don't need to do it. But yes. Actually, it proves that it's same important as in the hospital, and it's equally important and underestimated by both types of the facilities. Incident reporting is a very important diagnostic a mechanism to see the potential risks and then effectively mitigate them. So just to sum it up, we already talked, Dr. Ajbiki talked about the importance of access to care in the outpatient setting, to the continuity of care in the outpatient setting, which again, due to multiple doctors, due to short visits, due to various factors, we need to pay additional attention to ensure this continuity, so that you don't need to come and repeat all the time what your complaints are, and that somebody owns the patient. This is also very important, because it often happens if you come to a subspecialty doctor as a patient, and then the doctor just says, I see no problem in my area, go somewhere else. And then you go somewhere else, again, you tell all your story, and then another doctor says, in my area, there is no problem. Nobody owns the patient. So if you are an outpatient facility, you need to make sure that there is a process of transferring knowledge, and that doctors communicate with each other and communicate with the patient effectively. So patient communication was another important factor that we thought when we were talking about outpatient setting. Medication management was mentioned by both our speakers, so please pay attention to it as well. Infection control, obviously, and not only from the point of view of procedures that you are doing, but also from the point of view of isolation the patient from those who are potentially dangerous, and in outpatient care in the waiting area. Sometimes there is no triage at all. Yeah, somebody's coughing, somebody's pregnant, somebody has strange red spots, and they all sit together. So please pay attention to this area as well. Incident reporting as part of quality management, I also mentioned. Measurement, and Dr. Ali, thanks a lot for stressing this fact as well. Measurement and seeing the trends and analyzing if the trends is not going as you expected it to go, what's wrong. It's also part of quality measurement. And these are all the areas that basically are applicable for hospital. So for now, we haven't seen any area that is applicable for hospital, but not applicable for outpatient setting. And one more important thing, the role of infrastructure. And Dr. Ali, thanks a lot for mentioning that as well. Infrastructure safety in outpatient setting becomes as important as in the hospital, sometimes even more important, because patient might come for just a consultation with a doctor, not having any serious conditions, and then get a serious condition as a result of the incident because of the harm from the infrastructure, fall or damage the head or fall from height. Yeah, some facilities have balconies and barriers and strange holes at the staircases, etc., etc. So patient who was initially relatively healthy might get damaged and as a result of the outpatient setting. So please pay attention to it. So now I'm happy to introduce our third speaker from EHA clinics in Nigeria, Dr. Ifunanya Elodibe. You're welcome, Doctor.
Thank you so much, Maria, and thank you so much to the IFC healthcare team for inviting me. I'm just going to quickly share my screen. Please let me know if everybody can see my screen.
Yes, we can.
Awesome. So today, I have the pleasure of talking about three of my very favorite things, EHA clinics, quality, and primary care. And I've kind of, tried to find a funny title. I'll confess, I kind of stole it. I think imitation is the greatest form of flattery, right? And I called it Why Quality? It's just ambulatory care after all. And this is the outline we'll be looking at today. We'll talk about a little about who EHA Clinics is, what our core values are, and very interesting about our quality journey is why we even started it at the first place. Then we'll talk about how we went about implementing it, the challenges, and what the next steps are. And maybe at the end of this presentation, and all of my excellent webinar participants and speakers today will be able to agree that quality in ambulatory care is just not a nice to have. So EHA Clinics is a JCI accredited world-class comprehensive healthcare services, and we're located in Nigeria. And we really aim to bridge the gap between patients and healthcare services in any setting. So beyond even the clinic, we also look at the home and how we can increase access to care through innovative online and mobile solutions. We're equipped with the latest healthcare technologies, and we have a dedicated team of healthcare professionals, and we offer a unique range of patient-centered care. Currently, we run 7 primary clinics in Nigeria, in Kano, Abuja, and Lagos. And this is interesting because we opened our first clinic in 2018. This is about 6 years on, we now have 7 clinics, and 2 of those clinics actually operate as community clinics as part of what we call our REACH program. Our REACH program actually means reaching everyone with accessible community health. And these exist in low-income, underserved communities, currently in Abuja or Kano. So at the very core of who we are, our core values, of course, we believe that in patient-centered care, so putting the customer at the center of care, financial stewardship, if we're not good stewards, the doors will close. We also believe in impacting our patient population, our communities, and also our planet. And of course, we believe that we cannot do this without investing in our people. But very core to who we are is what we call our true north. And our true north at EHA Clinics is quality and safety. It really is the lens through which we look at every decision. If it's in the interest of quality and it's a little more expensive, we will choose that. And we like to give ourselves big, hairy, audacious goals, like zero harm, ensuring our patient population has improved health outcomes, that we practice and our patients get to experience high-performing primary care. And I will tell you a little about our implementation of lean healthcare as we go along. So I'm just going to tell you a little story, and I want to believe I'm a good storyteller. And this story is important because it is the reason we started, and it's the reason we do everything we do at AHA Clinics. So we actually have a parent company called eHealth Africa, who have been operating in Nigeria for over a decade at that point. And, they had gotten their staff excellent healthcare, but in 1 year alone, I think they had lost like 5 staff to, vaccine preventable illness, things that non-communicable diseases that were improperly managed. But I think what finally pushed the board over the edge was a story about a patient who had delay in diagnosis of a simple procedure like simple condition like acute appendicitis that now resulted in this person needing to be medevaced for appendicitis. And, at that point, the decision was beyond our public health interventions, how can we ensure that beyond our staff, our community has access to quality care? Not everybody is going to be able to be medevaced. So how are the community, people who don't have that opportunity, going to continue living in Nigeria? So we had to start with looking at what really was the problem in Nigeria. And, underfunding is a big one because it is the first domino that started the domino effect, because underfunding leads to infrastructure challenges, it leads to human resource shortages, it leads to inefficient healthcare system, poor electricity, no attention to quality, poor staff motivation, staff shortages because there's not enough funding in healthcare. But looking at the entire healthcare landscape and people's ability to pay, we realized the solution was not to open another secondary or tertiary facility because people could not really pay for that. But if we looked at our community and said, listen, if we evaluate patients in a way that we talk about preventative healthcare, we're able to get them into those annual health checks, get them vaccines, look at, how we can control communicable diseases. And Ajibike said something so interesting. 90% of what patients will need, we met in primary care. So, and primary care is more affordable, easier to set up, more accessible to patients. And, it was obvious we needed to think about primary care. But then we didn't want to think about primary care in the typical way that unfortunately primary care is perceived in Nigeria. Our PHCs are perceived as low quality, and that's why a lot of patients would rather go and have the atrocious wait times in tertiary facilities because of those perceptions. So we had to do primary care differently, and we had to do it thinking about the patient population, the infrastructural challenges, and what our unique approach was going to be. So there are 2 things we looked at. The first thing was the 10 building blocks of high-performing primary care. And I love the fact that I don't have to speak about this because the first 2 speakers did a fantastic job to evaluate what the challenges are in typical primary care and how these building blocks surmount that. Engage leadership. Quality is not a department. It is driven by leadership. And if you don't have leaders who are thinking about how patients get better outcomes and quality, then it's a non-starter. We had to think about how we implement data-driven improvements, how we make patients part of their own management, how we manage patient populations like hypertensive patients, thinking about empanelment and specialized team for monitoring and outcome measurement. We have to think about coordination and continuity of care, because like our speakers have said, when patients bounce around from doctor to doctor, sometimes you go to this doctor, you have to say everything you've said before. Sometimes you get to the doctor is you don't have an appointment. So even putting processes in place to coordinate patient care and then get information back from the specialist so that you can continue their care. Of course, prompt access to care, and I love that OneHealth thinks about that, because that's one thing that is a building block. How soon are patients able to get in to see a doctor when they need a doctor? But very importantly is looking at the future and what is the future of healthcare improvements, innovations, and how can we continue providing that care. And then we thought about implementing a quality framework. But to decide on that quality framework, we needed to do risk assessments. And so great that everything on this slide is everything that we've all talked about. Big one was diagnostic errors. We had a webinar 2 days ago on the impact of poor diagnosis on patient safety. And we actually did a case study on malaria misdiagnosis, which is probably one of the most common overdiagnosed conditions in Nigeria. And we had to look at what are the risks of diagnostic errors, either from the clinical assessment by the doctors, the vitals assessment by the nurses, the diagnostics, whether the samples are taken appropriately, whether the samples are run appropriately, are there quality assurance on the machines that are being used and then how critical results reported. So we also looked at medication errors, and Dr. Ali has said it all. Whether it's inappropriate antibiotics being given or patients getting medications they are actually allergic to, or inappropriate dosing, or lookalike sound-alike medication. Then we also looked at communication failures, and by nature, healthcare can be hierarchical. So if you have those barriers, sometimes the nurses are afraid to tell the doctors when there's an incident or a near miss, when patients are being passed on from healthcare provider to healthcare provider, missed information, inability to refer appropriately, and also communication failures on the part of ourselves to the patient, telling them which medications to stop, which medications to take, finding out which medications they are allergic to. Then, looking at the facility, patient falls, how, are we assessing certain patients who come in for risk of falls? How are we looking at our facility in order for us to provide support for people who may need support, or call doctors or nurses if they need support? How, even if within the context of ambulatory care, we're ensuring that patients, do not sustain fall. Preventable infections, why either is, as Maria said, either that's by triaging and knowing patients that should be isolated immediately, or even by something as basic as hand hygiene. Equipment failures, very common in our setting, especially because of poor lighting, even being able to get in good technicians to maintain equipment, and then incident management and sentinel events. And, which could be as simple as, the very sad story that Maria described. I mean, I can't count how many times we've had patients who come in for routine eye checks and we check their blood pressure and it's 200/120. That is a patient that could have potentially died, and, during a routine eye screening, and really assess these risks to determine the proper framework that would properly guide us and properly address all of these risks that we saw. And just like Dr. Ali said, we chose JCI. I mean, there are a lot of different frameworks we could choose. But JCI, we had more experience with it. A lot of us had come in from the US and different things like that. So we had a lot more experience with JCI. And then JCI's framework for ambulatory care just seemed to fit with the kinds of patients we were seeing and the kinds of risks that we wanted to manage. So how did we implement? Interesting to know that I was one of the core team that built the quality framework at EHA Clinics. So the first thing we had to do was figure out who was going to implement this quality framework. And I worked with some awesome women and our now Chief Innovation Officer, Dr. Ravi, to build our core quality team that was going to drive this initiative to get us JCI accredited. We started with a needs assessment. After the risk assessment, using the JCI guidelines, we needed to know what have we implemented today and where do we need to go? And during the needs assessment, we found out things like, our EMR didn't do pain assessments, we didn't have adequate fall risk fall prevention in the clinic. We had not kind of implemented adequate fire safety. And, when we saw the volume of work, honestly, I remember it was a 4-man team. We had to call for help. So we were lucky enough to get these awesome women as consultants who came to support us through our JCI journey and helped us to implement the framework. But very hard, one of the hardest things we had to do was deciding what to measure. The context of hospitals, there are some established things, readmission rates, catheter-associated urinary tract infection, things like that. But within primary care, it's a little different. But having the JCI guidelines was important. And we also looked at different things. So, of course, international patient safety goals, monitoring things like patient identification, hand hygiene monitoring, incidence of falls. We also did a hazard identification and risk assessment, and using that, identify areas of high risk that we could set as KPIs and monitor closely. We also looked at our national, international regulatory requirements, things like poison management, lookalike, sound-alike management, for KPIs. JCI has a care of patients chapter, and we also looked at the outcomes to monitor. It's easier to say, oh, patient had surgery, what is the surgical site infection in terms of outcomes, but how do you appropriately ensure that you're managing a patient with hypertension? Do you have guidelines in place, and how do you audit those guidelines to ensure? Then we also looked at patient complaints, which is a great place to start. I mean, one of the biggest complaints is wait time. So that became a KPI. Of course, regional health issues. Kano has a high sickle cell disease burden. So that became one of our disease of interest, which we included in our disease process audits. Challenges. And I will talk about the challenges and talk about some of the things we did, some of them a little more elaborately than others. So culture was a big part of big problem. Culture from a medical standpoint, where everybody's used to receiving orders from somebody at the top. And in order to build a culture of improvement and a culture of safety, you can't really have that. People need to feel empowered to speak up, to report incidents, near misses. People need to feel like their voices will be heard. People need to be able to address issues of patient safety. But even beyond the medical, it was also the environmental culture, the culture that says that, if you respect somebody, you don't speak up, and which cannot work with what we're trying to build. There's also a lack of regulation or standard. Sometimes you have ground to stand on and then start to build, but when you have nothing, it's a lot of reaching. A lot of the standards available are just the basic standards for opening a facility. Oh, you have to have licensed staff. Oh, you have to do this, or you have to do that. But even something as simple as credentialing was very difficult, because every council, clinician, every council, medical, pharmacy did it completely differently or had nothing at all. Lack of updated national guidelines. Some of the guidelines we saw were 10 years old. As we were trying to implement, guidelines within our SOPs, and a lot of the times we had to default to NICE guidelines and guidelines from the US. Then high attrition rates. I mean, our JCI journey was about 2 years, and in that time, you would train staff on international patient safety goals. You lose 20%, then you start again, lose 20%, start again, lose 20%. So we had to even think about how to keep training ongoing, because just waiting for people to do onboarding and then work in the system was not sufficient. So we had to think of a process that allows people to train and retrain whilst they are here on international patient safety goals, on using guidelines. getting the right talent to even build the core quality team, to implement some of the facility management standards that we needed to implement was problematic. It was novel. You know, we are the only JCI accredited ambulatory care facility in Nigeria and probably in West Africa. So even getting people who had prior JCI experience to build the frameworks that we needed was problematic. And it's still problematic today, but the good thing is that with the experience we have, now we're able to train our own talent. Independent consultants, because it's a primary care clinic, we, you know, most of the patients we deal with see medical officers. But of course, you know, we have gynecologists, we have ENT specialists, and most of these are contract. And really getting them to buy into our quality ethos. You know, what we had to do was look into, you know, competency assessments that took into account things like time management, patient complaints, antimicrobial stewardship. And in some cases, you know, we had to tell ourselves that even though, you know, this consultant is scarce, because quality and safety is our true north, we could not negotiate with this. So the specialist had to go. Managing referrals. Of course, it's an outpatient clinic, which means that we needed to be able to do what we could, urgent care in some situations, and send the patient to another facility. You know, even finding facilities of, you know, appropriate quality was problematic. And then a lot of the times they would go there and we'd be involved in this back and forth of not getting information, patients getting antibiotics they don't need, patient care decisions that you don't understand. I remember in one case, we referred a patient for transfusion, and we had gone as far as making sure that we got 3 units of blood and sent the patient with the blood, only for them to get there and forget the blood in the for the facility to forget the blood in the pharmacy, and the patients couldn't be transfused. And even lab services. So we have an in-house lab, but of course we don't run extensive, you know, beyond point of care testing and what we need for diagnostics there. And getting lab services that we could count on, you know, you send out urine culture samples and everybody will come back with staph aureus. So very curious, not able to be correlated clinically, and having to find, you know, partners that had ISO certification so that we could compare apples with apples. Then change management, even though we keep saying change is constant, nobody seems to like change. So when we started to implement JCI, and even to today, one of the things we struggle with is change management. You know, this is good for you, but you know, this is what we know is sometimes the easier conversation. Then of course, technology. You know, we had so many challenges with our EMR. We are lucky enough to have an in-house informatics team. So we broke it down, built it up, did so many things. And at a point, we completely pivoted and just built our own EMR. Of course, cost is a big consideration in implementing quality, because the reality is that the cost of services in primary care is inexpensive. So when you look at the cost of implementing quality versus the cost of the service you're providing, sometimes it doesn't seem to match, but we like to believe that quality is a business strategy. It's not an immediate one, but a long-term one. It guarantees business continuity. So if you're considering the cost, remember that the idea is not just to get all our money back in the next 5 years, but 20 years from now, do we have a healthcare system that we can be proud of? So I'm going to talk a little about culture, because this was a big one at AHA clinics. And we did 2 things. We looked at lean healthcare, and we looked at a framework called Crucial Conversations. And those of you who are quality people may have heard of lean healthcare. Lean traditionally came from engineering, and it's a system that looks at how can we minimize waste within, you know, any healthcare system, whether there are defects in the system that allow waste or motion waste or waiting or over-processing. And when you identify this waste, then you're able to create improvement plans and on how to minimize the waste. The good thing about Lean too is that it takes problem solving to the front line, where we're not just waiting for a manager to come and tell us what's wrong. We're having discussions in our daily huddles, and our team members are taking up the mantle of identifying these ways, doing QI project, and actually implementing change from the ground up. A very big one was crucial conversations, and crucial conversations is so important because communication in healthcare is probably one of the most important things. Crucial conversations ensures that there is mutual respect in communication with patients, but also with team members. It provides psychological safety so that people feel safe to report incidents. People feel safe that when you say incidents are non-punitive, they believe that incidents are non-punitive. It removes barriers, breaks down structures, and allows RCAs and root cause analysis to be more useful because everybody is psychologically safe. If you've never read it, if you've never done it, I highly recommend for healthcare. So how's it going? We got our JCI accreditation in 2022. We also went ahead to do ISO certification with SANAS for the lab in 2022, both in our Kano clinics. Like I said, we pivoted, we built our own EMR called EHA Care. The EHA Care allowed us to develop an application called our quality app, where we do all our chart audits, where we're able to implement clinical decision support tools and guidelines to allow clinicians make the right decision. We're also able to have a quality dashboard where we can, at one glance, know how we're doing. But we also Lean helped us to take quality, not just from the team, not just from the department, but to the teams, and talked about how we implement quality in our daily management system, which we call our huddles, which is every clinic, every day has what we call a huddle. I loved what Ajibiki said about preparing for patients, and that's what we do in our huddles. We know we have 5 appointments coming today. One of the appointments is for the cardiologist. This appointment may need a wheelchair, somebody is assigned, and the same thing for antenatal care. So those are the discussions we have in our huddle. But very importantly is that every day has a quality theme. We have safety Fridays, we have hand hygiene Mondays, we have patient identification for Wednesdays. We use that to keep reminding ourselves about quality standards that are important to us, or quality standards that we weren't doing so well in, but we decided to make part of our quality day so that we don't forget them. We also ensure that we have a monthly KPI review with all our teams. So it's not just at the managers meeting or the coordinators meeting, but at the huddle level. During our improvement huddles, we discuss all our KPIs, from IPSG to facility to staff and quality education, so that where there are gaps, we can all collaborate to make improvement. And then we ensure that every team at EHA Clinics has quality and safety as one of their OKRs, and they have at least 3 key result areas that they are tracking. And we've also ensured that we have annual JCI, ISO internal audits, just to keep the process going. So this is what EHA Care looks like, and I've kind of talked a little about that. This is what our quality dashboard looks like. We talk about how many records we audited, how many had incomplete evaluations. You can see that we also track appropriate handovers. This is our zero harm dashboard that talks about our medication errors we are monitoring, where we've seen inappropriate antibiotics being prescribed. And then this just shows an overview of our daily quality management system. So on our left is our Kaizen board, where we are monitoring our improvements conversations, and this happens at the daily huddles within the clinics. And on our right is our huddle board. We can see the number of appointments we have, what we're expecting, and if there's anything of interest we need to talk about. So what are the next steps? One of the big things we found out that no matter how we implement medication errors, we still got incidents of having either fake or bad medication that were not properly handled. So we started EHA Pharma, which is our distribution warehouse, where we speak directly to the manufacturers, imports, and distribute medication. And EHA Pharma is going for ISO 9001, 2015 this year. We're hopefully going for our JCR certification next year. We're going to increase our scope now so that we can include our dental and eye clinic. And very interestingly, I talked about lack of regulation and standards. Nigeria has just inaugurated a steering committee that will be responsible for setting up the National Health Facility Regulation Agency. So interesting times ahead. So I'm going to finish with this. Why do quality in ambulatory care? Do it because 80 to 90% of patients' needs will be met in primary care. Therefore, poor outcomes here will lead to higher morbidity and mortality in secondary and tertiary care. Do it because poor primary care will increase the burden on scarce secondary and tertiary care. And do it because we're all potential patients. If we do not build it, we will have to endure it. Finally, in the words of Nike, just do it. Thank you very much. And thank you so much for having me.
Awesome, Dr. Ifunanya. Thanks a lot. This was a great presentation. So thanks a lot to all our speakers. Today, we still have a very short Q&A session, I believe, because our speakers' presentations today are so rich in useful data that we are running out of time. Basically, we've exceeded our time already. So thanks a lot to all our audience for staying longer with us. We do believe that you found it useful. Sorry for keeping you a little bit longer. So now we're starting our Q&A session. And one of the most recurrent questions that we receive from everyone, basically, when we talk about outpatient care is actually waiting time. It definitely has something to do with access to care. So how to organize this access to care effectively. So, and what worked in your organization, what tips and tricks you can advise. Dr. Ajibike, Dr. Ifunanya, can you please advise to our audience?
Oh, wait times. I think anybody who cracks wait time will probably be the richest person in the world. Honestly, it is, I think that's the most QI project that we've ended up in. Like maybe we are in PDSA cycle 25 at this point. But I mean, obviously there are things like implementing appointment times, taking into account things like urgent care and emergency care into the implementation of appointment time, working, incentivizing patients that book appointments rather than walk-in patients. And, one of the things we always say is that you can teach patients to do the right thing. So if they show up on time, you take their appointment on time, they're likely to do it tomorrow. But if they show up on time, you keep them waiting. So you also have to practice what you preach, right? If you say you want to implement an appointment schedule, it means you have to have the I guess the willpower and the fortitude to keep them, and the discipline as well. And also it's also continuous improvement, right? One of the things we've done at EHA clinics before, we used to look at wait times as a whole. So you would have an average wait time. We've kind of tweaked the system a little so that, because a lot of time the average wait time looks good, but then when you tweak it a little, then you get to see outliers. And when those outliers happen, then you can kind of query the system. What happened in this case? How can we improve it? How can we make it better? I'll hand over to Ajibike now.
Thank you so much, Ajibike. Anything from you on this?
Nothing new. I mean, I think if he has covered everything, I guess there are two things. Definitely for Nigeria, people want to walk into a hospital and be seen 10 minutes. And you come at 10, but there are 100 people who have come before you, and yet you want to be seen and you want to go away. So the issue of appointments, I think, is important. We need to build in more appointment systems but make it easy for the people to book their appointments. And like she said, when they book appointments, try as much as possible to see them within time. The other thing I found that helps is communication with the patients while they're waiting. So if I'm waiting, what gets me antsy is I don't know if I'm going to be seeing in 1 hour, in 4 hours. But if somebody is able to say to me, your position on the queue is da-da-da, and your estimated waiting time is da-da-da, it helps to manage my expectations. If I want to step down the road to go and do something, I can go and come back or something. So I think we really should communicate a bit more with patients. Now, the workload is such that, especially in primary care and in more densely populated areas, and not for the high-flying clinics, but the clinics that, see a lot of people, we definitely should keep patients out of the clinic. So we need to think about how to manage patients such that they don't have to come back all the time. The public health aspect, self-management is very, very important. So we reduce the number of times that they have to come into the clinic, and that would help to improve the workload. Like he said, every clinic I know has a wait time project. The projects, the trainings we've been doing for quality managers in IFC, and we ask people to pick a topic. Almost everybody's talking about working on their wait times. So yes, please, anyone who gets it's like finding the golden fleece. Please let us know when you find it.
Thanks. All great points. Thanks a lot. Second question, I think can compete with the waiting time question, is how to make external consultants or doctors who are not your staff doctors to follow your rules and meet the requirements in patient safety, etc., and not try to manage it their own way like they used to do 50 years, 100 years more. That's what they usually say. I've always been doing it like this. I'm not gonna change if you ask me. So how to manage these situations? Any tips?
That's another very interesting question. I think what I've seen is it starts from how you onboard them, right? I'm lucky as the chief medical officer to have the opportunity to onboard consultants. I kind of tell them who we are, what our culture is. I tell them, this is a flat structure. My nurses have the autonomy to say, this is a patient safety risk and we are stopping this process. The lab have the autonomy to say, your patient does not have an informed consent for this and we're stopping this process. The pharmacists have the autonomy to say, your antimicrobial prescription makes no sense and we're stopping this process. And if you agree to this, do you want to continue? I think also working that into their service level agreements, right? Ensuring that, and I think Dr. Ali said something like that, within their KPIs, their standards of performance that are expected, which is their antimicrobial stewardship, their patient complaints, their wait time, things like that. Those are things that I see that have worked. Of course, in certain situations, you also have to know when to pull the plug and know that if quality is your true north, this is not a good relationship. But very, very important I have seen is what you say when they're coming in and how you structure their contracts to ensure that you are prioritizing quality.
Thank you. Thank you so much.
I agree with you, Ify. Bang on, right? You have to start on the right foot and let them know what's important to you. And so that when they sign on and you follow up. So it's not enough to tell them this is what is important to us and then you go away. Because when you go away and they slide back into their normal routine, it's very difficult to bring them back. So you have to follow up appropriately. I know that a lot of people will say, oh, it's easier said than done, because that's true. In a place where you have very few consultants or specialists and they can choose to leave you and go. And then I say to them, maybe you want to make your clinic or your hospital the place of choice to work. When clinicians go into a place where they're comfortable, their patients are comfortable, the patients want to come there, they would want to stay there, right? And it's not about making the process difficult for them. We need to support them to see how that process works and make sure it's workable for them. right? And like she said, at some point, you might need to take a difficult decision or have some difficult conversations. But yes, orientation, onboarding, orientation, follow-up, and making the path easy for them to walk. Thank you.
Thank you. Thank you very much, Ajibike. Unfortunately, we are running out of time. Thanks a lot for staying with us so much longer today. But we do believe that you found it useful. And we wanted to tell you that next time we plan to talk about the quality dashboard and how to measure, how to choose indicators, etc. So please join us for our next webinar. We will announce the date. We will announce the speakers and the topic closer to the event. So it was great pleasure to interact with you today. Thanks a lot for your great feedback in the chat. We already saw it. We are inspired by it. Thanks a lot for staying longer, for coming, for joining, for being active. And we do believe that we inspire you with our events, inspire you to change, to go and start implementing and making your facilities safer. Thank you very much and have a great evening, great afternoon. Bye-bye. Natasha, do you want to say anything?
Yes, of course. As usual, I encourage you to take care of the survey on exit. Please put your name correctly and put your email correctly. And email us in response to our invitation if you have any problems or if you have any questions. And we look forward to joining you in the next webinar, to seeing you in the next webinar. Thank you.